Welcome everyone to the eMedica National GP Trainee Teaching session number 10. So we're going to look at some AKT revision, we'll look at some consultation skills, and then we'll look at time management tips for both training and once you're qualified. We're going to start by looking at 3 AKT questions, 1 clinical, 1 stats, 1 admin. Then we're going to look at a key consultation skill. And finally, I want to talk today about something really important that can help you both in training, in different aspects of your role, your clinical role, thinking about your portfolio, thinking about revision for exams, but also when you're a qualified GP, it's a really, really important skill that's going to help you succeed, and that's how to manage your time well. And then we'll have a Q&A at the end. All right, so let's make a start. We're going to go straight into some AKT questions. So each of the questions, I will show you the question. You'll have 57 seconds to think about it, and then I'll launch the poll. Here we go. Here's the first question. So what we can see is that the 3 most popular answers are A, B, so ibuprofen, paracetamol, and then E, a supervised group exercise program. So these are the 3 most popular answers that you've picked. All right. Now, just for those that are new to AKT, this is a multiple best answer. So in the AKT, in a multiple best answer, it will say the number of right answers. So in this case, which 2 of the following? You have to get them both right to get the mark. If you get 1 right and 1 wrong, you won't get half a mark. You get no marks in the actual exam. Okay. So what do you think the diagnosis is, first of all? All right. Look at the scenario. I'll open the chat again. Type into the chat what you think is the diagnosis, okay, that this patient has got. We can see that it's about chronic pain management, but which type of chronic pain is this? Would you classify this as primary chronic pain or secondary chronic pain? Just type that into the chat. Because some questions are going to ask you to make a diagnosis, aren't they, rather than management. Yeah, so this is chronic primary, right? Why? Because there's no underlying cause of the pain. All right. A few people have said that this is fibromyalgia. There's not enough information here to just call this fibromyalgia. Okay. You'd need to look for specific features to say someone's got fibromyalgia. All right. So what we're looking at is in managing primary chronic pain, and it's chronic because it's more than 3 months, because that is for 6 months. It's primary because there's no underlying cause. Which 2 would be suitable? All right. So the correct answers are E and F. So very few people would have got the mark actually. All right, and that's because while quite a few of you picked E, in fact, it was one of the most popular answers, very few people picked F, and you'd need them both to get the 1 mark. If you get 1 right and 1 wrong, you don't get a mark. Lots of people picked ibuprofen and paracetamol. And this is a good example of separating the difference between what you think you might do if you had a patient in front of you and knowing the guideline, the knowledge base, okay? So there's a nice guideline on managing chronic pain, which just came out actually in April 2021. So for those of you that are going to be sitting the exam, the next exam is in the end of October, that would be long enough that it could be included. And often where there's new guidance, it's tested. That's why I specifically wanted to cover that today. Okay. So let's look at the definition first, and then what NICE recommends the non-pharmacological management options and the pharmacological management options. So chronic pain is pain that's lasting 3 or more months. So you've got chronic primary pain. There's no underlying cause that accounts for the pain or the impact that it seems to be having on the patient. And you can have chronic secondary pain where there is an underlying cause. So for example, someone might have, people had mentioned, for example, ankylosing spondylitis. That would be an example of something that could cause chronic secondary pain. There's an underlying cause that would explain why this person has got pain lasting for a long time. You see? Whereas if there's no underlying cause found, all right, that's primary. And both can coexist. So you could have someone who has an underlying cause that's causing some pain and it lasts for a long time. And then even when that's sort of not accounting for the pain, they might get other pains without an underlying cause. So they might have a chronic primary pain as well. Okay. And in terms of managing this, the bulk of the management recommended in the NICE guideline is non-pharmacological. So, i.e., talking treatments, exercise, physical therapy, alternative therapies, things like that. So all of these are recommended. Supervised group exercise, encouraging them to do regular physical activity, acceptance and commitment therapy. ACT is how that's sort of said. That's a sort of slightly different type of psychological treatment, similar to CBT, but not the same. Okay, CBT, cognitive behavioral therapy. And then interestingly, in this new guideline, acupuncture or dry needling, one course only, as long as it's done by a qualified practitioner. Okay, not recommended are these. So things like biofeedback, TENS machines, which physios often use for certain other types of pain, ultrasound, interferential therapy. These are not recommended of the non-pharmacological. And then for pharmacological, if they're 18 plus, the guideline actually talks about people 16 plus, but specifically in terms of medication, they split that into 18 plus and 16 and 17 year olds. So 18 plus, if you're going to think about a medication, it should not be an analgesic, it should be an antidepressant. So any one of these are recommended in the guideline. If they're 16 or 17, because we don't start these in primary care, if you felt that they might need medications, then you should refer them to psych, and they might start them on one of these, typically fluoxetine. Okay, no other drug treatments are recommended in primary care. Okay, so if we go back to the question, you see all of these would not be recommended because they're analgesics. All right, these two would be recommended. This one, there's a good evidence base for it, and a lot of people are surprised by that. Whereas TENS, there isn't a good evidence base for it. Okay, let's move on to question number 2. Great. Okay, so the two most popular answers are A and B, 14 days and 28 days. Okay, these are the two really popular answers. All right. So in a picture question, and the examiners have highlighted several times that any questions with pictures in, whether it's a dermatology, ophthalmology, or something like this is in the admin domain about rules and regulations, people often struggle. So it's really important that you look at both the picture and the scenario. So if you look at the scenario, they've been taking the top dose of codeine for cancer-related pain, and it's not helped, and now they've been given a new prescription. Now we have to look at the picture to find out what have they been given. So they've been given tramadol 100 milligrams 4 times a day. So 400 milligrams of top dose of tramadol. Now you can see why, because anyone know what's the top dose of codeine? Type into the chat if you know what the top dose of codeine is. Yeah, so the top dose of codeine is 60 milligrams 4 times a day, 240 milligrams. Okay, and tramadol 400 is stronger than that, in that the strength of tramadol and codeine is the same. They're both 10 times weaker than oral morphine. But with tramadol, the maximum dose is 400, whereas 60 milligrams QDS, the maximum dose of codeine, which is 240, so it's significantly less opioid. Okay, so we've stepped up basically. And so they're going to be given 60 tablets of this. So how long is the prescription valid for? The correct answer is B, 28 days. Now, something really important here. Doing well in the AKT is a mixture of primarily having the knowledge, having put the hours in, covered the material, covered the curriculum, done the work. But a big part of doing well on the day is exam technique. Reading the question carefully, understanding what the examiner means, picking out certain keywords. So for example, here, it says, how long would this prescription be valid? This is about rules and regulations. How long is a prescription for a controlled drug, like tramadol, valid? So it means valid from this date. It's not asking, how long would this cover the patient for? Because someone might think, okay, if it's 4 times a day and they've been given 60 tablets, that's 15 days worth of tablets. So that the closest thing to that is 14 days. This prescription would cover the patient for just over 14 days. It'd cover them for 15 days, but that's not what the question's asking. The question's asking, how long will the prescription be valid? The pharmacist will actually give you any medication for it. If you took this 29th of the 4th, you've got 28 days. If you presented this in June, they would say to you, I cannot legally give you the medication on this prescription. You need to go and get a new prescription because it has become invalidated. Okay, it's 28 days, not 1 month. Why? Because the regulation says 28 days. It's not a month. Why? Because most months have 30 or 31 days. It's only February that has 28 or 29. So it's, again, the knowledge side is knowing that it's 28 days, not a month. The technique side is reading that it says, how long would the prescription be valid? Whereas if you said, how long would this prescription provide pain relief for this patient? Then it's 15 days, isn't it? Okay, do you see how it's important to both have the knowledge base, but read carefully? So controlled drug script validity, this is in the organizational domain. Controlled drug prescriptions, so controlled drugs are in schedules, schedule 1, 2, 3, 4, or 5, okay? So controlled drugs are in schedule 2, 3, or 4 are all valid for 28 days. Now you can forward date it. So for example, this prescription from today, but if I wanted the patient not to be able to access it until 2 weeks time, I could put the start date here, the date, I could put the 15th of May, for example. The pharmacist won't let them have it before that. From that date, they've got to cash the prescription in, if you like, within 28 days of that day. Or you can actually write valid from and put a specific date in the future here if you want, okay, in the body of the script. Schedule 5 scripts are valid for 6 months, which is also the standard validity of any other medication, the script, okay? So here's another question that you could be asked. What schedule is tramadol? You can see, as it's 28 days, it's 2, 3, or 4. It's not going to be schedule 5, because otherwise the answer would have been 6 months. So which schedule is tramadol? Do you think it's schedule 2, 3, or 4? Let's see what people think. Great, so most people have got this right. Well done. It's a schedule 3 drug, okay? Tramadol is a schedule 3 drug. So controlled drugs are categorized from schedule 1 to schedule 5. So schedule 1 are the most strictly controlled. They've got little or no therapeutic value. They tend to be highly addictive. They're basically not really used in primary care. They're used in hospital in trial settings only, okay? And in a lot of cases, they're not used at all medicinally. They're categorized because they're so strictly controlled. So things like cannabis resin, raw opium, LSD. Schedule 2, these are of high therapeutic value, often also highly addictive, but they're very strictly controlled because they're dangerous. So strong opioids, diamorphine, morphine, oxycodone, fentanyl, pethidine, medicinal cannabis. Okay, so, which can be used, for example, in children with very resistant epilepsy, for example, amphetamines. So these are really strictly controlled. You've got strict regulations about how they need to be kept in a locked container, in a locked box. When they expire, someone needs to denature them, then they need to be witnessed as being destroyed, things like that. Schedule 3, slightly less strict control, but you still do have prescription safe custody requirements, okay? Just not as strict as Schedule 2. So things like tramadol, temazepam, midazolam. Then you've got Schedule 4, which is in 2 parts, Part 1 and Part 2. These have got minimal control. You don't need the safe custody requirements. You don't need the same handwriting and the prescription requirements that you do of Schedule 2 and 3 drugs. And then Schedule 5, these are the lowest control. Some of these can even be sold over the counter, like low-dose codeine. A lot of people don't even know that codeine is a controlled drug. Low-dose, low-concentration liquid morphine. So, for example, 5 milligrams in 10 mils is actually Schedule 5. You do need a prescription for that, but it's Schedule 5 because it's not very dangerous, okay? Whereas high concentration liquid morphine and all tablet morphine forms are Schedule 2. Okay. last one, stats. Here we go. Okay, now this is a free text question. So in the exam, the free text question, there's no options to guess from. You'd actually type your answer into the box. So, okay, so let's have a look now. This is one of the newer style data interpretation questions. So this data is real life data about a real life practice, Heath Lane Medical Centre, okay? And I've got this from Public Health England's website. So you'd actually type your answer into the box, and the correct answer is skin cancer. Now, if you just put skin, you'd get the mark. If you put skin cancer, you'd get the mark. Anything else, you wouldn't get the mark. All right. If you mistyped skin, again, it's okay. The computer would recognize that. But you know, someone that put breast or GI or lung, they wouldn't get the mark because it's the wrong answer. So let's have a look at what we're actually looking for here. The great thing about this, there's no maths, there's no calculation. It's just if you can spend a bit of time getting familiar with looking at different types of real data, it makes it a bit less scary when you see it in the exam. Okay. So what we're looking at here is basically, this is the benchmark. The benchmark in this case is England. You could set the benchmark as other practices in your CCG, but in this case, the benchmark is England, okay? And then what you've got here is, you've got this value here in the middle. You've got the 75th centile and the 25th centile, okay? i.e. 25% of practices will have a value smaller than this number. 75% will have a value smaller than this number. This is the highest one, this is the lowest one. And then if you look at the colors are standardized. So yellow means that it's similar to the benchmark. And you can see that, you can see it's within this sort of gray bit here, within the box, okay? Blue normally means that this practice is got numbers that are higher. And purple normally means this practice got numbers that are lower, all right? So the question's asking, they've got a much higher referral rate, okay? The number here, the count, this is the actual number of referrals, but we're interested in the rate. The rate is the value. So this is the rate per 100,000 population. Now, very few practices have 100,000, so you extrapolate, okay? So, you know, if your practice got 2,000, if you had only 2 referrals, as a rate, can you see, if you want to compare it, it's not fair to compare that to a practice who's got 10,000 patients, but the rates are comparable, you see? So if you work out a rate per 100,000, so you can see that for skin cancer, they had 104 referrals, but as a number per 100,000 population, that's 1,382. Now you can see that's much higher than the England value, which is 831. And you can see that visually, first by this color, and you can see it's far outside the gray box. Whereas most of the other things, they're near the gray box or just above, or in this case, just below, okay? But here, they're much above, and that's what the question was asking for, all right? Now, why might that be? Why might this practice be referring, because this is about referrals, referring far more suspected skin cancers compared to, you know, other practices in England? Can anyone think of a reason for that? Type into the chat. And similarly, they've got far less lung cancers, okay, as a rate. Look, 27 per 100,000, England average 107, so about a quarter. Why could that be? Why might they have much lower? So someone said location. Yeah, great. So for location, for example, let's say that this is, like if you had the other way, if you had one with lots of lung cancers, it might be an ex-mining or a mining town, okay, like I did my GP training in Neathport Talbot in South Wales. There are a lot of communities there where a big part of the industry and a lot of people working in the mines, okay? And so there might be higher levels of COPD and things like lung cancer. Why might there be a higher rate of skin cancer? Well, if you've got low rates of lung cancer, you might have, let's say it's a university practice. You might have, a lot of people, for example, who travel a lot, higher risk for melanoma, but that wouldn't really explain it because you still get more cancers as we get older, even skin cancers. So what might explain that? To give you a good example of what might explain this. This practice might have someone who's a GP with specialist interest in dermatology. So they might be in this practice, not just seeing their own patients, they might also be seeing patients from other practices who've been referred in, and after they've seen them, they might then refer them on as a 2-week wait, because things that say other GPs aren't sure, does this need to be seen, or they've got a what they think is a fungal infection, is not responding. They think, go and see the GP with specialist interest, and then they might then be referring them on because they recognize an atypical type of skin cancer, for example. So that might explain why they might have so many more referrals per 100,000 for something like skin cancer compared to other practices. Okay, so things that you want to look at is understanding that this is the actual number, this is the rate, this is the rate in the locality, CCG rate, this is the rate in England, average for all of England, basically. Okay, and then this is the lowest value and the highest value. Right. Now, in terms of AKT, for those of you that are maybe starting to think about the October exam or next year, a couple of things that will help you. We've got lots of free support for AKT. So, if you're not already a member of the GP training support group, and we've also got an AKT study group, and someone in the team will post links to these in a minute, please do join them. I regularly post information about free webinars we hold. There's revision posts in there regularly. The last 30 days before every exam, I post one video with a question, high yield question, like we've done 3, one high yield question and a review every day for the last 30 days before the exam. And then the past versions of these national VTS, this is the 10th one. We also did 9 lockdown learning in the first lockdown back in March 2020. The recordings of all of these are available on our YouTube channel. So again, you can watch, we've got over 25 hours worth of CPD. It's all free to access on our YouTube channel. And then I've finished writing, but the MPS are finalizing the design of an AKT study guide, which will be coming out very soon. I'll post that into the groups. So, if you're already joined, you'll see it in the group when it gets posted. And then for those of you that want additional support, we have our paid courses. So from our most structured and most comprehensive resource, which is our AKT Pass Guarantee program, which there's 2 versions. You can either do this over 90 days or over 150 days. So the 150-day program for the October exam, for example, will start at the end of May. And the content and the learning in both programs is exactly the same. The only difference is the 150-day program, the first 4 months, you get every other day an email from me with questions to do, reading to do, online revision to do. There's 9 webinars, there's 2 full-day courses, there's over 3,500 questions, there's a whole load of full mock exams, there's daily learning. You also get a tailored, the first 6 days we gather data, the last 30 days you get an individually tailored plan as to what you need to cover more to get you across the pass line. Okay, so that, and the 90-day is every day, so it's more intense, but the learning is the same in both. Okay, so the 150-day, people just have a bit more time in the first 4 months to do each bit of work. The 90-day, every day you've got 24 hours, you've got to get the work done, you're going to get more work. Then we've got our AKT Pass Plus bundle, which is 110 hours. Okay, it's got slightly less live sessions. It's got the same online revision. It's got some of the full day courses. Then we've got our full day AKT course. We've got our AKT Master Class webinars covering stats, admin, high yield clinical. Our AKT 200 question crammer course, which we've been running with RCGP Beds and Hearts as a national revision course. And a good starting point for people that aren't actively revising, maybe you're going to sit the exam, I don't know, maybe next year, you just want to get a head start, an idea of the exam and make a start, you might do a half-day revision course. Okay. We also have online revision, 2,150 plus questions mapped to the new RCGP curriculum, similar layout to the real exam. And we have our clinical case cards for the clinical domain. These were updated in 2021 with the latest guidelines. For example, you can see things like COVID-19, SARS-CoV-2, these are only recently added to the notifiable disease list. These are the latest impetigo guidelines. Okay, so we're going to move on to consultation skills now. Okay, and really the big consultation skill I want to focus on today is the power and importance of acknowledging cues, picking them up and acknowledging them. Okay, so cues come in different types, don't they? Patients can give us verbal cues, they can give us non-verbal cues. So what's a cue? A cue is just a clue, all right? Now, sometimes they're really obvious, but sometimes they can be a little bit more subtle. And that's why it's really important that you listen carefully, you look carefully, you pay attention, even more so when you're doing a remote consultation, where sometimes, it's more difficult to pick these things up. So let me give you some examples of cues and how you might actually use them. So the first thing is verbal cues. It's really important to listen carefully to exactly what's being said, and then to sort of reflect it back and explore what they mean by it. So a good example is sometimes a patient might say something in passing. They might say that, this pain's really severe and, it's got me worried. Now, what you might have heard is that the pain is really severe, and you might explore that. And that's, of course, important. You do want to explore how severe it is and what could be causing it. Don't forget that you're a doctor. You could look at the clinical side. But if you don't explore and it's got me worried, and don't reflect that, you said it's got you worried. Can I ask, what has it got you worried about? And maybe they're worried that because of how severe it is, the painkillers aren't helping them. Maybe they previously had an addiction to opioids, and they're worried that paracetamol isn't helping, and they might have to take codeine again. They're more worried about it took them a long time to come out of their addiction. Maybe they're worried about something entirely unrelated. They're worried the fact that the pain's so bad they can't go to work, and they're worried about losing their job, and their partner's on furlough, and so without their income, they're going to really struggle. You see, if you don't pick up carefully that, and it's got me worried, and then even if you do pick it up, if you don't reflect it back and explore what they mean by it, you could miss it. Similarly, sometimes it's not just what's said, it's the way it's said. So you might ask a patient if they smoke, and they might say, I don't smoke. Okay. Now, if you look at those three words, I don't smoke, look how if the way they say it, not just the word, but the way they say it is slightly changed, it might have a different meaning if you listen carefully. So they might say, I don't smoke. What might that mean? If the patient, rather than saying I don't smoke, they say I don't smoke, so the emphasis on the I, what might that mean? What might you pick up from what they're not saying there? So what you might pick up from that is that maybe someone else in the house smokes. So, you might say, you said you don't smoke. Does someone else in the household smoke? And they might say, oh, actually, yes, my partner smokes. And maybe they're worried about their partner's health, okay? Or maybe there's the risk to them of passive smoking, or maybe there's young kids who've got badly controlled asthma, and that's what they're worried about. And, but they find it difficult to ask their partner to give up. Or maybe, it's a family where, the parents are separated or divorced, and whenever the child goes and stays with the other parent, they come back and they're wheezy and they're coughing and they're worried about it. Do you see? So it could be that. What if they don't say, I don't smoke? They say the same three words, but the emphasis is in a different word. What if they say, I don't smoke? What might you take from that? So not I don't smoke, and not I don't smoke, but I don't smoke. So the emphasis on the word smoke. What might we take from that, or what might we explore? So it might be that they don't smoke, but maybe there's something else. You said you don't smoke. Is there something else that you want to share? Well, actually, I've been so stressed, I've been drinking more. Or maybe they vape and they don't consider that smoking. Or actually, something else to ask. Sometimes it's also the way that you ask it. Like you might ask, do you smoke cigarettes? And someone might say, I don't smoke cigarettes. So they've not emphasized the I, they've not emphasized the smoke, they've emphasized the word cigarettes. What might that mean? Well, maybe they smoke cannabis. Maybe they smoke cigars. Maybe they use shishas, the water pipes. Okay, so using a shisha pipe for an hour is similar in terms of risk and damage to smoking 100 cigarettes. That's what some studies have shown. All right, but a lot of people that use shisha, they don't consider that smoking. You see, so sometimes, do you see the importance first of listening carefully to pick up some of these subtle things? All right. Similarly, sometimes something can be really subtle. Okay. So, for example, a patient might say that, I've got a lot going on at work, doc, and there's a few things that are concerning me. And if you don't pick up that they said a few things, and you just deal with the main complaint, and you don't say, we said that there are a few things, we've talked about this, is there something else that you wanted to talk about? They might not then bring up the secondary thing, which actually might be really important to them and might be something serious or significant there that needs to be explored. So that's verbal cues. It's important to listen carefully. Watch out for not just what they say, but how they say it. Watch out for sort of throwaway comments, and maybe there's a hidden agenda there. Then maybe there's something else that needs to be explored. Maybe there's a concern that needs to be explored in more detail. Then you've got non-verbal cues. Okay, so sometimes it's not about what someone said, not about even the way they've emphasized the words, but it's about not the words at all, non-verbal cues. That's why it's important to watch carefully and to say what you see. That's a way to, again, acknowledge that you've seen it, both to them, but also for those of you that are going to be preparing for RCA for the examiner. So I'll give you an example. Let's say now I've come in and I had a Wellman health check, one of these NHS health checks. I actually was called for these a couple of years ago. All right, you get called for it when you're over 40, and they check your blood pressure. They sent off bloods to check like my kidney function, HbA1c, cholesterol levels, things like that. Okay, and then a week later you'll come back for the results and to have a discussion. So let's say now I've come back for that, and you're the doctor, and you say, how can I help today? And I say to you, I've come back for my results, doc. And then you say, oh right, okay, well, what were you expecting? Well, I had that check. They did all those bloods. They said my blood pressure's okay. I just came back for the results. Have you got the results? Now, the patients actually asked for the results, but what do you notice? In terms of non-verbal, what do you notice? You see, they seem like they're not that engaged. I seem like I'm avoiding eye contact. I'm speaking in a low tone, not really engaging. Maybe there's something there. Now, if you just say, okay, well, we've got the results, your cholesterol's fine, you're not diabetic, your sugar check was okay, your kidney function's fine, well done, great. And then the patient's like, okay, thanks. And then off they go. You might miss something. Whereas if you say what you see, I hope you don't mind me saying this, Dr. Rahman, but while we've been talking about your results, you've been looking down, you're speaking much quieter than normal, especially if you know your patient. This can be really, you will notice the difference. So I hope you don't mind me saying this, but it seems like there might be something else going on. You seem a little bit down. Now I might have that wrong, but I just want to ask you, is there anything else going on? Is there anything else you'd like to discuss, or how have you been feeling lately? And you could maybe go into sort of, once you've acknowledged that and they open up a little bit, actually I have been feeling. I've been feeling a bit stressed, to be honest, with all this pandemic. Well, I'm sorry to hear that you've been stressed. That word can mean different things to people. What does it mean to you? And then they might say, well, I've been feeling a bit upset. And now you've got a clue. You could maybe do a little screen for low mood. And if they screen positive, you might take a full depression history, for example. You see, so sometimes just acknowledging that. Or sometimes someone just seems really nervous. They're fiddling with their watch. They're sort of, seem agitated. Again, I hope you don't mind me saying this, but you seem a little bit uncomfortable. And they might say, well, actually, I'm finding this difficult to talk about. Maybe they're embarrassed. Maybe they're nervous about something else. So sometimes it's not what they've said. It's like their behavior, or eye contact, or lack of eye contact, or things like that. So again, say what you see. It can be a way to open a door to find out what's going on behind there. And sometimes they might not want to talk about it, and that's fine. But sometimes they might really be desperate to talk about it, but they don't know how to bring it up. But once you've acknowledged and show that you're willing to listen to other things, because they might think, oh, my appointment was made for my bloods. They might not want to listen to anything else. But once you give them permission to say something else, they'll often open up. And then, there might be something really important going on there. Okay. So, these are some really important things that you can do, both verbal and non-verbal cues, that, listen carefully, watch out carefully, say what you see, acknowledge what's going on, okay, and then explore, and that can help you find out what's going on. All right. Now, just in terms of resources that we have available to help people who are preparing for either the RCA, or those of you that are maybe about to start your first GP practice rotation, and you may be not familiar with a lot of the kinds of things that you might see in GP. So you might find helpful our CSA 100 case cram. So there's basically 100 GP cases. For each one, we go through what are the key things in history, what are the red flags not to miss, how to do the examination, what are the current guidelines for management, How might you explain it in terms of the interpersonal? How might you explain it in clear language? Some of the other things to think about. So it's over 8 hours of videos. It's a full day course that we recorded, basically. It covers 100 different cases. With it, you get a PDF version of this booklet. So it's 100 cases. We do sell the booklet separately. Some people just like to have the paper version. So, like we cover, for example, here's dyspepsia, case number 3. You've got the key things to ask in data gathering. You've got the red flags that you absolutely mustn't miss. You've got what are the current guidelines for management, how you might explain it, and so on. So it's like a 350-page booklet. So you get the PDF version of that with the videos. And then for those that are preparing for RCA, we have our RCA Master Class, which is a half-day webinar that we did covering, how examiners will mark your consultations, techniques to improve your scores, how to get good quality recordings, how to pick your cases so you don't get penalized for low challenge cases. What are the reasons that people fail and how you can avoid them? We've been teaching for CSA for over a decade. We've been teaching for RCA since the very first sitting. It'll give you a clear plan. There's also 6 interactive cases, so you can see examples of things to do, things not to do, okay? And then for those that want individual practice with feedback with professional simulators, our full day flagship RCA course, we only take 9 doctors, okay? And then for that, there's a male simulator, a female simulator, myself, and another assessor, okay? So that everyone gets lots of individual feedback. You get to see 25 cases in the day in total. You also get access to this as part of it before you come, and some additional videos on how to structure a consultation, how to break bad news, the mark scheme in detail, and afterwards you get access to 65 cases to practice, okay? So the next date available is the 10th of June, so this is for people planning for the September or November RCA sittings, which are the last 2 for 2021. There will be one in July. That's only for doctors that failed the March sitting, okay? And then we've launched a new bundle. I'll just show you that. So when you go to our website, the eMedical website, everything for AKT is here, everything for RCA is here. So if you look here, our new bundle, that includes before the course, you get the videos from the RCA Master Class. You also get pre-course videos for the course. On the day of the course, 25 cases. After the course, you get access to our CSA 100 case videos, plus the 65 cases to practice, but you also get 2 hours of one-to-one coaching. Okay, so this is our new bundle, okay, that we've just launched. Some people wanted something even after the course to get more one-to-one coaching, okay? So that's that. So the next date is June. And then the last session I want to talk about today for the last 15 minutes is time management tips. And some of you might be wondering, why is there a tomato here? We'll come back to that in a minute, okay? So time management tips. The system and things that I want to think about can be sort of shortened into 3 PO, because there's 3 Ps and there's an O, all right? So the 3 Ps are plan, prioritize, Pomodoro, which is Italian for tomato, okay? And then Ohio is the O, all right? So let's go through each of them. So the first thing is to plan. If you are conscious, you actually think about how you manage your time and what you use your time for and plan it out, you're much more likely to then be able to manage it well, all right? Because a real big problem in GP training is that it's so busy, the day job, you're so busy with your work, keeping up with things like the e-portfolio, finding time for things like revision, keeping up with your workplace-based assessment, the different logs that you need to do, all of that, it can be really challenging, okay? And so you need to think about planning at various levels. So you could think about planning on the sort of day-to-day and week-to-week basis. So things like, on a given day, do I have dedicated time to deal with my paperwork? In a given week, when will I have time allotted to make sure I put some learning logs every single week into my portfolio? If you're preparing for one of the exams, what's my timetable like in terms of study? Every day, am I going to study half an hour before work, half an hour after, 10 minutes in my lunch break? What's your timetable? So that's like a granular level, day to day, week to week. But it's as important as doing those things is thinking about things that are going to look after your well-being. Because if you are in good mental health, if you are in good physical health, it's going to allow you to do these things better. So you've got to also fit in time into your day and week for exercise, for relaxation, for eating well. So being able to plan ahead and cook so that you're not having to eat junk, you're not having to always get takeouts. Sometimes we have to, but if you can plan, You can batch cook, you can freeze things in advance, you can still have healthy things. So that's important. Then you've got to plan a bit more long term, i.e. at a monthly level, or maybe at a rotation level. So things like planning your annual leave, because not every week you'll have annual leave. So, that doesn't come into it. But, in a rotation, you're definitely going to have some leave, right? So things like annual leave, study leave, planning, if I want to go on this course, when is that course? What are the regulations in my deanery if they require 6 weeks notice? If I don't put it in advance, even though I could have got funding for it, even though it would be a useful course, they might just say it's too late now for us to approve it. Do you see? So that would be a real shame. At a rotation level, I've got to get this many assessments. I've got to get this many practical procedures signed off. So I've got to make time to get those done, because if you don't actively go and seek out your supervisor and say, I need these signed off, I need you to do these mini clinical exercises, I need to do these, what you'll find is that they're so busy, and especially in hospital jobs where often there isn't sort of particular time put aside by your supervisor to think about your assessments. Okay. Whereas in GP, your trainer often has specific time for tutorials. That if you're not proactive, you might not get signed off, and that might mean that you have to repeat a rotation, or you don't do well in your ARCP. So you've got to think about these things, and then you've got to think about things even broader at a year level. Like, when is the right time for me to sit my AKT? When is the right time for me to plug in my RCA? How am I going to meet the requirements for ARCP so I can progress from ST1 to ST2, from ST2 to ST3? So planning is really, really important. You've got to actively think about these things. Otherwise, it's really easy that you get so busy that you find that I've never got time to do any of these things. You come to ARCP. I've seen people who've actually passed their exams, but had to extend their training because they hadn't got enough learning logs, because they hadn't got all of the assessments on the workplace-based assessment. Okay, so you don't want things like that to happen. So that's planning. The second P is to prioritize. And to prioritize, you can use this. This is called the Eisenhower matrix. Okay, that look at your task list. Actually sit down, go through, maybe in a week, go through all the different things that you need to do, and then think, okay, how urgent are they and how important are they? And then you can put things into these different boxes. So, there are certain things that are of high urgency and high importance. You want to do those first. Then you've got things that are important but not so urgent. You probably want to do those next. You've got things that are urgent but not really important. You can actually do those a bit later, or sometimes you might be able to delegate those, because even though they seem urgent, because they're not important, if they are delayed, it doesn't matter. Do you see? Okay. And finally, you've got things that are not urgent and they're not important. You can delay those significantly, or sometimes just don't bother with them. You can bin them, leave them. Okay. So let's think about some of the things that would fit into each of these boxes. So what are some of the things that you might have to think about in your work that are both urgent and of high importance? Can you think of some examples? Type into the chat. Okay, so a good example of something that's urgent and important is if you're on call and you've been paged about a patient who's really sick and they need a review. You can't delay that, can you? They've bleeped you. You can't delegate that to someone else. You're the one that needs to go. You need to go and do that first. All right. Equally, something that's urgent and important would be, let's say now you have got a deadline to apply for your AKT. Passing your AKT is really important to you. The next sitting is a good one for you because the rotation's relatively quieter and you think you'll be able to have time to study. The one after that's A&E, so it's not going to suit you. But the deadline's today. Do you see, there's an urgency, there's a time limit, and it's important. If you miss it, it can have a significant impact on your plans for the next year. Okay, so things like that, you see, you want to get them done first. All right. Then you've got things that are not urgent, but they're really important. So for example, there's no urgency. If you're in year 2, you can't you can't sit and you can't even record anything for your RCA, to record your consultation assessment, until you're in ST3. So this is something really important, but there's no urgency to it if you're still in ST2. But it's important. So what we mean by do next is that you at least need to put a plan as to when you're going to do it, or start thinking about it. Because let's say you think, what, for me to be able to pass that exam, I need to improve my communication skills. That's something you can start practicing. That's something you can say, okay, to your trainer, look, I'm going to be in ST3 in 3 months. Could we use some of these tutorials for you to assess my consulting and give me feedback? Because I like to improve. So by the time I start ST3, I can hit the ground running and start recording. Okay. There's not an urgency because you've got lots of time, but it's important. So if you don't think about it, and at least think about how am I going to deal with this and put a timetable to start, okay, you might get to the point where actually it's too late now. Because for your trainer to have time to observe you, might take a few clinics for them to observe you and give you valuable feedback for you to start making changes. Okay, things that are important and not urgent, if you don't at least think about when you're going to do them, what happens? They become urgent and important, and then you might miss them. Okay, so then you have some things that have an urgency to them, which means that there's a fixed deadline, but they're either not important or it's not important that you do it personally. So these you could either try to do later, before the deadline, because there's still an urgency, or you could say, look, I'm going to see if I can get someone else to do some of this because it's not important that I do it myself. All right. And, you know, if you do delay it a little bit, and ultimately, if, for example, it means that it doesn't get done because it's not important, it's not going to have a significant impact. So an example of that would be there's an audit meeting coming up and you've been asked that, you know, if you'd like to take part in this, you've got to submit the data by the end of tomorrow. So there's some urgency, consider the deadline. Now, you've already taken part in QIA in this rotation. So if you didn't do this, ultimately it wouldn't impact your progression, your ARCP, because you've met the requirements. Okay. But it'd be nice if you could take part. All right. So you might see, okay, look, I'll leave this till later. If I have time, great. If I don't, I've got my minimum to be signed off. So it's not that important if I don't get it done, you know, but there is a deadline. Or you could say, look, the deadline's tomorrow. Could I maybe get an F2 to collect some of the data and then I can look it over with them? They also get to be part of an audit, but, you know, I still also hit the deadline and get to deal with those things that are important as well beforehand. Okay. So do you see? Okay. Then you've got things that are neither urgent nor important. You know, so you might have, anyone think of an example of something that's not urgent and it's not important either? So like there might be, I don't know, a film coming out next month and you wanted to get some cinema tickets for it. Now, it's next month, so if you don't do it now, you can delay it. It's no problem. In the end, even if you don't watch it, you could watch it when it comes out on TV eventually. If you didn't bother, it wouldn't have a big impact on your life. Okay, do you see? There are some things that might have different importance to different people. For example, you going to your fitness class, that might be really, really important. If it's today, it might also be urgent. All right, you know, you making time to book annual leave and thinking about a holiday, that's very important. But if your annual leave isn't going to be for another month, it's not urgent. You see, so it can help you just prioritize what you're going to do when. All right. And then the other P is the Pomodoro technique. Okay, so Pomodoro, as I mentioned, is Italian for tomato. All right, and so Francesco Cirillo is the person that invented the Pomodoro technique. So you can look that up if you want to get more details of it. But essentially, I've been using these for many years to help me be more productive in my time management. So what the Pomodoro technique is that, and it's called that because as part of this, you know, people often have a kitchen timer. He happened to have a kitchen timer which was in the shape of a tomato, and he'd use this for timing his work intervals. So what you do is you break your work into fixed time intervals. So the classic Pomodoro is a 25-minute interval. Okay, but you could set your own. Okay, and so like, you know, I have this timer. So I'll set like 25 minutes on it, and then it beeps, and then I have another. It's got two timers. So they've got 5 minutes at the bottom. So for 25 minutes, I'll have no interruptions. I won't check my phone, no social media, no checking the Facebook group, no answering other people's queries on the Facebook group, no getting involved in comments, no, nothing else. Okay, I just focus, monotasking. You know, I might just be writing AKT questions. I might just be working on slides for updating a new course. I might just be writing a proposal. I might just be dealing with, you know, bloods. I might just be dealing with reading clinic letters that have come through on document. Whatever you do, you just focus on one thing. Okay, and you do it for 25 minutes. You'll be amazed how much work you can get done. Similarly, you could be doing studies. You might say for 25 minutes, no turn my phone on silent. I don't want it pinging and there's a notification. I check someone's Instagram, and then you go into a black hole. Now you've seen that one. It shows you another one, and you start tapping it. And I'm going to do one set of questions, as many as I can in 25 minutes, or you might say 40 minutes or whatever. Then you have a 5-minute break. Then you do another one. When you've done 2, you might take a longer break, 10-minute break. Do you see? But you just focus on one thing at a time and do it with no interruption. So, you can use this for paperwork. You can use this for 25 minutes. I'm just going to write learning logs, and then they're going to be done. Whereas, if you do it and then you hear a ping, and then you go on a website, then you check social media, then, you get a call and you call them and take that. What happens? All of these things happen. You get distracted. It ends up, you say, it takes ages to do this. I don't have time. There's not enough time for me to do my learning logs. It takes me 2 hours to do one. In 25 minutes, you could write all your learning logs for that week if you just sat down and did it in one Pomodoro, in one pod, okay? And finally, the O is for Ohio, not the state in America, but only handle it once. This can really help, and you can use this with the Pomodoro technique. So, things like paperwork, bloods, clinic letters, referrals or dictation. If you only handle it once, what do I mean by that? So what someone will sometimes do is they've got a pile of bloods that need to look through, or, some documents or some bloods on the computer. Like in hospital, it might be actual physical printed bloods. And what some doctors will do is they'll scan through them just to look for the ones that are abnormal, and the normal ones they'll leave there. Then they'll come back and deal with the normal ones later. That's a huge waste of time. Because if you've looked at it and it's normal, just sign it and then it can be filed. You only handle it once. When you come back, you're still going to have to look at it again. You're just duplicating time. Similarly, if you're doing DocMan, you're doing, looking through clinic letters that have come back, okay? If you say, this is my dedicated time for this admin, I'm going to take these 25 minutes, then I'm going to go for my lunch break. In that pod, you see a letter. If it needs an action, right, do the action there and then. Right, it needs another referral based on this blood. Okay, dictate the referral, type the referral, it's done. This one's normal, sign it normal, send a task to admins to file, okay? Whereas if you think, that one's normal, I'll leave it, I'll come back and deal with those later, you're going to end up having to look over it again. You're just duplicating and a waste of time. So wherever possible, only handle things once and just they're done, okay? It will save you a huge amount of time. Another thing that can help is things like referrals or dictation. If you had a clinic, some patients need a referral letter, and you might be running late and you're busy and you think, I just want to see the next one. If you ideally do it after each patient, I try to type the letter before I call the next patient in, okay? If you don't do it, then at least do it at the end of clinic. What you don't want to do is leave it to the end of the day, because then what's going to happen? If you do it after each patient, everything's fresh. You're only handling it once. End of clinic, you still might remember mostly. You might just need to look at it. End of the day, you're going to have to look at the whole entry again to refresh yourself about what it was about, because you've seen 30 other patients in between, okay? So just to recap, you can use all of these different things to manage your time better. So, plan daily, weekly, monthly, rotation, annually. Prioritize what's urgent and most important to do first. Use pods of monotasking, of focus time, okay? Pomodoro technique, and only handle it once. These can all help you manage your time better, both in training, and I still use these things today, as a qualified GP for many years, okay? You go. Please do join the GP Training Support Facebook group if you're not already a member. It's the biggest group for GP trainees out there, over 23,400 doctors. Subscribe to our YouTube channel so you can get the video, which will come out in a couple of days. I'll ask you for feedback and what things you'd like covered next month. Do fill it in. Tell your friends if you found it helpful. This is our YouTube channel. So recent videos, Dr. Raj Dhaliwal got the highest score in the AKT in the last round, 97%. I interviewed him and he's talked about how he prepared and things like that. Thank you so much for joining and giving up your evening. For those that are fasting, hope you have a nice iftar. Please remember me when you're breaking your fast. And for everyone else, keep pushing, keep going, prepare, and you will succeed. Huge thank you to the eMedica team for all of your help and support.